My name is Julie, and me and my Group 7 members, Darla and Emily, are going to be presenting on hospital readmissions and payment penalties. Before we begin, I would like to discuss the basics of hospital readmissions and payment penalties. Hospital readmissions consist of patients being readmitted within a certain time frame, usually 30 days past initial admission. These most commonly result from defects in care, medication errors, lack of necessary equipment, and unpreparedness of the patient and family for care after discharge. It seems as though hospital readmissions may indicate issues in quality of care and as a result lead to worsened health outcomes. In an effort to curtail the care and cost issues of hospital readmission, the Hospital Readmissions Reduction Program was established in 2012 under the ACA. Under this program, hospitals are penalized and reimbursed less for services if readmission rates for certain illnesses are high. These illnesses are broadly defined as heart attack, COPD, heart failure, pneumonia, coronary artery bypass surgery, and elective hip and knee replacements. As we will discuss later, the primary goals in imposing these financial penalties are to lower healthcare costs and increase quality of care and patient satisfaction rates. Since this policy has been in effect, there have been reductions in readmission rates, but some critics are quick to counter this success with underlying issues. While the program was seemingly able to reduce readmission in both targeted and untargeted conditions, more recent studies of the program showed overestimation of the actual decline in readmission rates. Overall, it would be beneficial to impose a standardization of hospital readmission policies and best practices so that analyzing rates and establishing long-term success in lowering hospital readmission rates is more accurate.
Recently, widespread and intensive efforts to reduce excess hospital readmissions have been stimulated by heightened awareness of both prevalence of readmission as well as new financial penalties linked to readmission rates. 14.9% of Medicare beneficiaries were readmitted to the hospital within 30 days of discharge, and 34% were readmitted within 90 days, with a national average cost of readmission amounting to around $13,000. The cost of readmissions to the healthcare system is substantial, accounting for an estimated $17.4 billion spent annually by Medicare alone. Another aspect to consider is that readmissions were associated with new post-discharge complications related to procedures performed in the hospital. This brings up the idea that readmissions rate are caused due to complications in procedures, potentially establishing a pattern of hospitals with lower quality of care, considering equal amounts of invasive procedures. Along with that, from this image, we can observe how patients who are non-adherent and have comorbidities are more likely to be readmitted than those with caregivers or who manage their diseases effectively. There are also certain disparities seen in readmission rates. A black to white disparity in hospital readmissions has been observed. Among black and white Medicare patients hospitalized for surgery, Black patients were 19% more likely to be readmitted after adjusting for comorbidities, type of procedure, and location of care. This observed disparity was mediated in part by poverty. For homeless individuals, the 30-day inpatient hospital readmission rate was 50.8%. To battle this issue, interventions to lower readmission rates are being utilized and established, such as patient coaching, telehealth service, discharge summaries, and follow-up after discharge. Screening tools exist to identify seniors at high risk of readmissions. Also, the Hospital Readmission Reduction Program that Julie previously mentioned imposes financial penalties on hospitals with excessive readmissions. This curbs fee-for-service and inpatient billing incentives that hospitals may have to make more money. We have reduced hospital readmissions over the past decade, with the Affordable Care Act being a catalyst to that shift, but there is still work to be done to continue to reduce these costs.
The cost of readmissions of patients to the healthcare system is estimated to have cost Medicare alone $17.4 billion annually. Because hospital readmissions have grown to be such a problem, the Affordable Care Act established the Hospital Readmissions Reduction Program. This allows Medicare to reduce payments to healthcare facilities with high readmission rates. The risk standardized readmission rates for the last 3 years for acute heart failure, pneumonia, and myocardial infarction are calculated, and those determine the penalties. Hospitals with high readmission rates are penalized 1% in year 1 of their CMS reimbursement in the first year of the program, and up to 3% of their CMS reimbursement in the third year of the program. These penalties have been successful in reducing excess readmissions in hospitals. To wrap things up, here are 2 questions for you to consider. What action should be taken to address the racial and socioeconomic disparities we see in hospital readmission rates? And do you think that doctors and hospitals will find a way to commit Medicare fraud by not being transparent about readmission rates to avoid penalties? If so, what action should be taken to prevent this fraud from happening?